Yeah, Bridie, give a thumbs
Yeah,
up.
thanks, Bridie.
While we're waiting for people to enter, start with a little bit of trivia. Students from Newcastle, whose names I don't know. What is this?
Elbow joint.
Elbow joint. And what is this?
Tailbone.
Otherwise known as? You actually do know your elbow from your ass. That is all you need to understand when looking at x-rays, that you know anatomy. Stop trying to guess what the dysfunction is or whatever else. You're not trying to pass an exam here. You're just looking at anatomy, and the anatomy should be just the normal anatomy or something slightly different. But stop trying to guess like zebras when it's just, where is the front, where is the back, where is the arms, where is the not arms, and so on. Like, don't overthink any kind of scan. You need to understand your anatomy that simply. Can you tell an elbow from a backside? Yes. That you know enough to know what you're looking at. And assume you know what you're looking at. Stop trying to think it's something weird just because you haven't seen it before. Yeah. A kidney is a kidney. Where does a kidney live on yourself? Everyone, point to where a kidney lives. Out there somewhere. Yeah. Just one. Two. So if you see things kind of looking vaguely symmetrically, two of them, that's the kidneys. Yeah. Where's your liver? Everyone's pointing to their right side. Anna, who I have taught this to before.
Oh, it's a bit.
So one of the confusing things about scans is the left and right side. Yeah. So you think about a scan like you're looking at me. Is that my left arm?
Mhm.
Left side, right arm. Yeah, like you're looking at the patient square on. Yeah, that makes sense. And the same with CTs and MRIs and stuff like that. If you're standing at my feet, yeah, that's my right arm. So on the scan, that'll be the right side of the head and the left side of the head, which will be opposite world in terms of the TV screen. Does that make sense? So you're thinking about an image as a circle based on you standing at their foot end.
Like this for those not in the camera. Thanks.
What is the blue thing?
Trachea.
Trachea, and then it branches into the carina's where it splits into the bronchi. And then from there, it's very important. Do you actually see the airways tracking through the lungs? Yes or no? Look at it. Do you see airways running through lungs? Point at an airway, Lucy. Why are you nodding? If you're saying yes, you got to point at something. What you're seeing is blood vessels. You're thinking about the white things. What are the white things? Blood vessels. But you don't see air next to air. There's no difference in density. So you don't see airways running through things. That becomes important when you're using the phrase air bronchograms. Yeah, and we had a version of that, didn't we? Hello?
Is that Rachel?
Yeah. She's just in here. There we go. So this is the hilum, and the hilum is where the blood vessels and the airways enter into the lungs. Yeah. So the white stuff is water, and in this case, the water is in the blood vessels. Does that make sense? And this white stuff is the heart, and the water is in the heart. Yeah. But you can't tell the difference between the different chambers of the heart, can you? Can't tell the difference between what is blood in the ventricle and the muscle wall. This is not sensitive to that. On a CT scan or MRI, it would be. Make sense? So we don't see those differences in density between the water that is blood and the water that is muscle here. We'll get to the finer details of what this looks like. But to some degree here, you need to understand that this is the normal anatomy inside a chest, and the white stuff is these structures. So some very important points is this is the right side, yeah? And the right side comes down to the right atrium. And the right atrium has a thing above and below, which is the vena cava. Is the vena cava an artery or a vein? Vein. So it's where all the blood comes back to the right side of the heart, to the right atrium. Yeah. And then this red one is the
Aorta.
aorta. And that's where the blood leaves the left ventricle and it runs down. And we'll see this again when we're looking at a CT scan or something like that. The aorta runs down the left-hand side of the vertebral bodies. Yeah, see in the middle here would be the vertebra. And then that would be down the left side of the vertebral bodies. And sometimes right about here, you see this beautiful little circle, which is the top of the arch of the aorta. And the reason you see that sometimes on X-ray is that it is not just water anymore, but calcified. And then again, pulmonary arteries and pulmonary veins are not really distinguishable from each other, but that's where they are. And if you see too many blood vessels, there's too much blood in the blood vessels. Fluid overload, pulmonary edema, that kind of stuff. Right. Lungs. I'm sure you all had to sit through a lecture where somebody told you that with a stethoscope, you could tell the difference between an upper, a middle, and a lower lobe. I give you, ladies and gentlemen, a triple point. No, I can't. Well, I've done this for a while. Just call it a zone. And yeah, right here, you got like all three things in one place and they overlap quite a lot. So upper zone on the right, upper zone on the left, lower zone on the right, lower zone on the left. What you really need to understand. And even the purpose of that is, why would I care whether somebody's left lower zone was problematic? What do I want to do with that information?
Is it in your treatment? Or
What would my treatment be if there's a left lower zone opacity?
Or if it's sputum, it could be like positioning,
So what position would be the wrong position to use?
left side line.
Yeah, left side down. Don't do that. Of what's left, what is one achievable, i.e. if you can't move them, can you move them? No. So does it matter? No, you can't do anything with that information. Yeah. Always put what you're looking at in the context of what am I doing with it. Because if you had the perfect answer to somebody's chest X-ray, you can't touch them because they're banged up, like our guy's banged up. What are you doing with that information? Well, it's just a good intellectual exercise of how many busted ribs can we spot? And we will look at that, see how many busted ribs you can spot. So, the diaphragms. The importance of the diaphragm is understanding that the diaphragm should be visible and clear. And below the diaphragm, and the diaphragm itself is what is the diaphragm? What is the diaphragm? Talk.
Muscle.
A muscle. What are muscles made of? Mostly water and protein, yeah? So is water a different density to air?
Yes.
Yeah. But what is the liver made of? Water and protein. So the diaphragm is not a different density to the liver. Makes sense? Whereas on this side, you've got the diaphragm, and below there you have something that is air density. Yes. And where is that gas?
Stomach.
And is that normal? Because where are we pointing? The left or the right? And where is your stomach? Left. Called your gastric bubble. And if you're looking for a nasogastric tube, should it be somewhere in the vicinity of that gastric bubble? Yes. And not in the right main bronchus, as sometimes we find them. The other important part is you should be able to see the diaphragm behind the heart. That is called your cardiophrenic angle, because you have diaphragm that is water, lung that is air, and then heart that is water. So you see differences in density. If your heart and your diaphragm blur into each other, are there any black pixels in between the white pixels? And what is black pixels? Air. So are you lacking air? Then use whatever version of atelectasis, collapse, whatever, I don't care. Just say less black pixels. So that's all you're looking at. Black or white pixels. Too many of one or too many of the other. That was the gastric thingy, and sometimes air within the colon. And if we see air within somebody's colon, what do we need to do? Pull their finger. The answer is always pull his finger. Yeah. Why? Because if you had an abdomen full of stuff, yeah, as you have after you've eaten too much, is it easy to breathe? No. So if somebody pulled your finger, would it make it easier to breathe? Is that going to be more effective than asking them to take deep breaths? Yeah. It's equally effective to saying, putting your hands on their ribs and saying, cough COVID in my face, please. So bones. Checking for fractures is a whole other special skill, but I just want you to think about following this edge with your finger or with the mouse or with your eyeballs. And if the edge has a discontinuity to it, that is a fracture. Another guy, I swear he looks like he's dislocated his
Yeah.
clavicle, but I don't know. Nobody else has mentioned it. He's got enough other things broken that
Yeah.
we don't care.
Yeah.
But you would not look at one of these to determine spinal fractures. Maybe a lateral, but even then. This is just to demonstrate that anything you want to know is available on Instagram. The number of talks I've made by scrolling through Instagram going, here's some people I follow, screenshot, drop it into Google Slides, shop at work and present. I don't need to learn what I need to talk about. I've done this for too long. And also I've learned that teaching you less stuff is better. Not more stuff. I don't need references for this. The anatomy hasn't changed since before I was born. But the most important thing is that the first rib is very hard to find. And then when we're counting ribs, I count actually transverse processes. So T1, 2, 3, 4, 5, 6, 7, 8, 9, 10, getting to 11 and 11 and a half. How many fingers do I have? If I don't get to 10, are they well inflated or underinflated? Underinflated. And if I have to use my toes, hyperinflated. Yeah, does that sound like a bit of an obstructive disorder, being hyperinflated? Yeah. And if somebody is hyperinflated, should I be doing inspiratory techniques or expiratory techniques? Yeah, because if they are already hyperinflated and you get them to inhale harder, what's going to happen? Going to get better or worse? Worse. Deep breathing is not the answer to any question. I'm telling you, I said that. Does that make sense? That's the purpose of something. It's guiding what you want to do. Yeah. If somebody is underinflated, yeah, you're only counting to 8. Will deep breathing help them? No, because the radiographer asked them to take a deep breath before he took the scan. So the words deep breathing only get you to 8. Yeah. So what do we do as physios? Ask them to do the same thing. Everybody stand up. Taking a deep breath in and out through your mouth. Now go back to your crappy sitting like a student. Everyone taking a deep breath through your mouth. Everyone got louder, yeah? Him particularly. Yeah, some awake apnea. No, so awake obstruction. It's harder to breathe and you're shifting less gas. Did I use any different words? No. I changed your relationship to the earth, which changed your FRC, which changed your work of breathing. I don't have to mention any of that. Yeah? What do I do in ICU? I tickle their feet, put red socks on them and stand them. Yeah. How many times do we use a stethoscope to assess somebody's chest?
I used one yesterday.
I used one today because we had a guy sitting on the edge of the bed and he was real interesting and the student was there. I'm like, here's a stethoscope. Listen to that. What are you learning? Oh, that sounds just louder than what I thought it was going to sound like feeling him. Yeah. Might do that once a prac, if that. But the idea is, if you're not actually just checking their straight leg raise and standing them up, treating them, you're trying to not treat them. You're just wasting time. Yeah. Now, if you're in a crappy position and I auscultate you, have I learned anything other than you're in a crappy position? Yeah. So should I get you out of bed, sit you in a chair and then auscultate you? Sound like a more sensible thing to do? Put them in the good position, then listen to their breathing. Rather than learn, well, of course you'll have less. So can you cough it out? Can you breathe through it? Will the doctor still ask you to give them incentive spirometry to try and fix it? Will that fix it? No. This is not an answer to any question other than you don't know what you're doing. So I again, like part of what I want you to think about this is, and certainly in the cardiothoracic patients that we see, 3 kinds of thoughts about fluid. It's clear, it's kind of just an ooze from protein issues or whatever else, or just fluid overload. It's cloudy, infective, or it's red, which would be. Yeah, so either they're traumatic or what's the other reason why you're going to have red stuff in that space? Patients, Brenda. Dying. Cancer. Yeah. It brings us to the prettiness of a CT scan.
Bloods.
It's trauma, don't worry.
So this is a CT scan. So if I'm looking at this, you're looking at me lying on my back, which would make this my right side and this my left side. Now, what is this thing right here? Vertebra. So is that my back? Yeah. And is that thing going in that way? What is that? Rib. And what is this bony thing at the front?
Don't worry.
Sternum. And what is this in between my sternum and my back? And or other heart and blood vessels. Make sense? People know this and they go, oh, I don't know. I'm like, no, dude, use words of anatomy. So this gives you a lot finer detail. As you can see in here, we have a difference between the stuff that is the heart versus the stuff that is the blood vessels versus the stuff that is connective tissue versus the stuff that is fluid in the pleural space. This guy right here is nice and pretty. So we have black lines running through white stuff. So what is black? Air. And what kind of runs in long lines that is full of air? Airways. Capillaries. Your capillaries are full of air. You're going to die. Yeah. So you've got air in the airways and you have white stuff in the lungs. And that is water in the alveoli and interstitial. That is the consolidation version of this, yeah? It is water in the lungs. Whereas see here, this is a different shade of white, or even the same shade of white, but it doesn't have airways in it. So if it doesn't have airways in it, is it lung? It's between the rib and the lung. So it is pleural fluid. And then people will use different versions of opacity to describe all this other stuff. But opacity versus solid looking mass, yeah? Versus, for some reason, there's bowel up in this person's chest. Doesn't like bowel. A bit to me. What is the problem when the bit of your bowel's up in your chest?
Herniation.
Kind of hernia? Yeah, hernia, correct. We had somebody with this in ICU.
Hiatus.
Hiatus hernia. I guess if somebody looks like they have a loop of bowel above their diaphragm, that's the problem. That make sense?